I think I have the honor to introduce my good friend from the day we started our practice, I think more than 20 years. I still remember Jyoti starting a conference, and now it's grown to a big national event. I congratulate you, Jyoti, and the team for this every year, excellent, improving every year to greater heights. Jyoti needs no introduction to this great audience, but just a few. I think he's a organizing chairperson for the national RSDI, which is going to be organized in Kochi, and national president for the Diabetes Technology Trust of India, Central Executive Committee member, RSDI Aero, Editor-in-Chief of International Journal of Diabetes and Technology, and Management Trustee of Kesavadev Trust. And I'm sure that all of you know that he has lots of publications, both national and international publications to his credit, a lot of research and a lot of work in the field of diabetes. Over to you, Jyoti. Thank you.
Thank you, Johny. Johny is my dear friend for many, many decades. And thanks for those encouraging words of introduction. So we were listening to your brilliant discussion on pancreatic exocrine deficiency, and next is a lecture on insulin. So some of you may be wondering why on insulin, because yesterday we launched a new GLP, and that was Wegovy injection semaglutide, a breakthrough molecule. So in this session of JPEF, we have launched two path-breaking treatments and one technology. But still, all of you should understand that insulin has got a space, and that is a huge space in the treatment of diabetes. And that is why we have included insulin, but this insulin is an analog premix insulin. So these are my disclosures, and this lecture is supported by Cipla. And Humalog mix is originally from Lilly, marketed in India by Cipla. And all the pictures that I am using in my presentation, they are AI generated. So I will start with a simple case of a 65-year-old gentleman with diabetes of 18 years duration. And this is the complaint for which he has visited you in your clinic. Let me tell you, this session is going to be an interactive lecture, and there will be one or two gifts for some of these quiz. So you can be ready with your answers. And this guy has a hemoglobin A1C of 8.2%. And this is a very common scenario in our country. Despite being on 2, 3 or 4 oral therapies, the hemoglobin A1C remaining high, higher than normal. And out of curiosity, it is conventional for me to ask this question. And this is again AI generated, the doctor and the patient. Looks very exciting. And out of curiosity, I used to ask my patients, why are you not on insulin despite having diabetes for 18 years? Did you deny insulin? Did you deny insulin despite your doctor advising this? And this is the answer. No. My doctors have never suggested insulin, but this I don't believe. Because the doctors who are updating the knowledge, the doctors who are following the guideline-directed medical therapy, they will definitely go only by the clinical guidelines. And the clinical guidelines keep on changing. And now, of course, there are subtle changes in the guidelines for insulin as well. And this inertia could be the inertia from the part of the patient and not necessarily from the part of the doctor. Moving on to another very common scenario, in diabetes and in obesity, there is currently 2 to 4 times higher chances of malignancy. We discussed about the use of GLP-1 and how you can prolong the lifespan and how you can reduce even the occurrences of malignancies. But malignancies are very high, and during the treatment of malignancies, even those didn't have diabetes, those who don't have diabetes can have a new onset hyperglycemia. And how many of us, so look at the glucose levels of this lady, and this is a new patient who met me, fasting of 220 and a postprandial of more than 300. So are we giving, or are they giving, the oncologists or the cancer centers or the hospitals, are they giving any priority in the management of hyperglycemia during the course of treatment of malignancies? I think the answer is very obvious, and you do have the evidence currently that if you are intensively treating the glucose, which is extremely difficult in the wake of malignancies, because during the treatment of malignancies with chemotherapy and with steroids, they may require very, very high doses of insulin, and preferably should be on continuous glucose monitoring devices. Forget about malignancies. And this is a general scenario. And this is a recent data, 2024, low and middle income countries. Even in those who are receiving treatment for diabetes, even in those who are accepting treatment for diabetes, only 15.7, less than 16% of those will have control over their glucose. That means the vast majority of patients getting treated for diabetes, they are developing the complications such as coronary artery disease or stroke or other sequences, including chronic kidney disease and now the chronic liver disease, and all of them are preventable, but they are still developing the complications of diabetes. And the reasons could be multiple, but let us discuss the disease burden. I have a question to you, so be ready with the answers. And I have 5 choices for this question. What percentage of people with diabetes in India, they continue to have a hemoglobin A1C of equal to or above 7%? Who will be supporting me? You will be there. So Bridget will be supporting me. So whoever answers first will get a prize. Despite being on 3 or more anti-hyperglycemic therapies, what percentage of people with diabetes will have uncontrolled glucose despite being on 3 oral agents? 10%, 25%, 45%, 65%, and 80%. You have to go there. Quick. One of you can stand up and answer. Who said 80%? For you it is 80%?
65%.
65%? 65%? 45%? 25%, very optimistic. Yeah. 10% only, okay. So you are very, very optimistic. So who said 80%? And he is the winner. You can introduce yourself, and Anjana, you can hand over the prize.
I am Dr. Harisoman, Hari's Diabetes Center, Paripalli.
Thank you. And you have been a consistent attendee of JPEF for many years. Thank you very much. The answer is 80%. So 80%, because remember, more than 80 to 90% of people with diabetes getting treated, they are developing complications. And this is because of multiple reasons. And one reason is increase in the A1C. So they are on multiple therapies, but still 80% of people with diabetes in India, they have A1C equal to or more than 7. And these are multiple other epidemiological studies. And the recent one, the ICMR India study, where the A1C average in India is close to 9%. Still it is 9%. And the postprandial levels are close to 250. So you know the 2-hour postprandial glucose levels need to be below 140 preferably. Of course, there are exceptions, but this is too high for India. So the control of glucose is suboptimal. And this is despite the availability of cheaper therapies, older therapies, newer therapies, and the availability of guidelines from even our own RSSDA. So Dr. Rajiv Chawla is sitting in front of me, and he himself initiated our RSSDA guidelines. And we keep on changing every 1 to 2 years. And this is a risk of uncontrolled glucose. And I think everybody sitting here is aware of the risk of postprandial glucose levels. And if I make a statement that PPG or a spike 2 hours after the meal above 140 or above 180 is responsible for retinopathy, is responsible for a higher risk of CA pancreas. That is not completely true. There are multiple factors responsible for all these complications. But the statement, which is a reality now in 2025, is almost all of these are preventable and can be addressed, provided the treatment is individualized. Very important that it has to be individualized. And look at the continuous glucose monitoring data, and this is something which is pivotal in practice now, strongly endorsed and recommended by all the organizations. And this is a classical ambulatory glucose profile report consisting of 3 elements. One element is the TR matrix, the second is the ambulatory glucose profile, and the third is the individual days of glucose monitoring. And there is a pronounced, look at the significant peak after the breakfast, a less significant one after the lunch and after the dinner. So this is something which is uniformly observed in people with type 2 diabetes getting treated with medications. And if you are aiming for a time in range of more than 70%, which is probably compared to who here the time in range is 43%. Just 43% of the time the glucose is remaining normal. And if you are aiming for more than 70%, which is equivalent to an A1C below 7%, you probably should be targeting, in addition to fasting, a PPG at 2 hours below 140. So in all the previous clinical trials, what we have observed is, when you are trying to bring down the glucose, there is a proportionate increase in the occurrence of hypoglycemia and hypoglycemia related mortality. So we need to be extremely careful in choosing therapies with lesser occurrence of hypoglycemia, and hence newer insulins are important. GLP-1 based therapies are much more important. And insulin in the Indian context, and this is my next question, at approximately what level of hemoglobin A1C in India? In India, what is the average A1C level at which insulin therapy is started by the doctor or the patient?
So 10.
10. Okay. 10. I can hear.
9.
9. Okay. 12.
10. 10.
Okay, the answer is 9. The answer is 9. This is a recent number. Earlier it used to be 10, 12, but now it is 9.
I am Dr. Gopinath, cardiologist from Erode, Tamil Nadu.
Congrats.
Thank you, sir.
Yeah. We didn't take a picture when we are... we have taken the picture. Thank you very much. Okay. So the average hemoglobin A1C in India, when you start insulin, is 9%. So that translates to, or that implies that you are starting insulin therapy after approximately 6 to 7 years of diabetes, by which probably many of them could have already developed complications. They could have developed neuropathy, retinopathy, nephropathy, and then only you are starting insulin. So actually it is not for prevention of complications. So if I ask you, of course this is not a quiz question, the commonest preparation, the commonest formulation of insulin being used in India, it is premix. Ideally it could have been a basal insulin to start with. But many of us, including me, we start treating with the premix insulin because of multiple factors. The carb content of the diet is very high, of course. That is known to everyone. The predominant reason being, it is a delayed insulin initiation, and the patients are usually previously on multiple oral agents, including sulfonylureas, where a premix insulin is required. And one more question. In the RSSA guidelines, so we are all part of these guidelines, recommend starting premix insulin at what dose? Is this dose correct or not? 10 to 12 units once daily. Is this statement true or false? Hidesh?
So true.
It is true. Any difference of opinion? All of you agree that it is a true statement? I think you are the winner. It is a true statement. Shalini agreed? Shalini agreed. So it is a true statement that you can, yeah. It is true that you can start with 10 to 12 units of a premix insulin, and the premix analog insulin is administered approximately 15 to 20 minutes before a meal. A human insulin, a premix, is ideally administered 30 to 45 minutes before a meal. But premix analog is much better when compared to a human premix insulin. And it can be started once daily, or if required, it can be started twice daily. And this discussion is about a very old formulation. It's not a new drug, and this has been around for more than 20 years, but still highly relevant because insulin is not initiated at the right time. But is insulin sufficient? Is insulin and oral drug sufficient for managing diabetes? No, no. The most important component is when you are pairing your treatments with the technology. Monitoring is of utmost importance. You have to monitor your glucose. If you need to prevent the complications and you ensure that there is an enhanced quality of life for your people with diabetes, preferably with a continuous glucose monitoring sensor. And yesterday at JPEF, the technology launch was the new Libre 2 Plus technology, which doesn't require any scanning. And this is meant for 15 days with the highest accuracy. So the best sensor in the world has reached India, and that is the Libre 2 Plus. And if the patients cannot afford, or if you cannot convince, then definitely you have to go for a glucose meter, and that glucometer should be a connected glucose meter. So this is tailoring the insulin initiation with a low mix. Low mix is when the ratio is 25/75. So when you are having a homolog mix 25/75, this is an example of a 60-year-old gentleman with 8 years of diabetes and the hemoglobin A1C of 9.3%. Look at the fasting and 2-hour PPD, 170 and 280. So the numbers are very high with early chronic kidney disease, and he has come to you for uncontrolled diabetes. And this is a very common scenario on Depa, Sita, Metformin. And they may be on a single drug because combination therapies are available. And when you keep on adding one more oral therapy for diabetes, the A1C need not come down. The A1C can remain the same. And how to decide on which insulin formulation to be started? This is a rough guidance. If the postprandial increment is more than 54, the psychological factors for convenience, for comfort, and for limited resources available for a person to intensify the insulin starting at once daily and then gradually stepping up twice daily. So in this example, for a postprandial spike, PPG minus fasting will be 110 for this person, which is definitely more than 54, and hence it shouldn't be a basal. The choice should be a premix insulin, so that it is the patient is comfortable, and you can step up the dose. You can make it even twice daily, and this is the clinical evidence. In modern medicine, you require evidence. So whatever statement you are making, to get incorporated in a guideline, you have to generate evidence. And this is a clinical trial where more than 2,000 subjects were there comparing Lispro premix, that is 25/75, against the basal insulin. So this is Glargine, the world leader in basal insulin. But when you are comparing the two, the hemoglobin A1C reduction is more with premix. It is more durable. For a longer duration of time, the A1C is normal, and the percentage of people with an A1C lowering below 7 is also significantly more with the premix. And with equivalent number of hypoglycemia, all insulins can result in hypoglycemia. All insulins. The only difference is the newer analog insulins are having a significantly lower risk of developing a hypoglycemia. And this is high mix. So high mix is when the ratio is 50/50. And in another example, a 51-year-old with 10 years of diabetes, hemoglobin A1C of 9%, and here again the difference between fasting and postprandial is huge, and there is early chronic kidney disease and on multiple medications. Here, the person is also on sulfonylurea. So most of those people with a diabetes duration of 8 years or 9 years or 10 years definitely is going to be on sulfonylurea such as glimepiride or glycoside, where they will definitely require either a premix insulin or a basal bolus insulin. Basal alone will be insufficient, and this is the glucose monitoring data of the person. Very high postprandial values. I prefer a digital glucose diary. Most of our patients have a digital glucose diary so that the data is in the cloud, and the mHealth application along with the connected glucose meter comes with no extra cost. And nowadays it is getting replaced with the continuous glucose monitoring devices where the LibreView and the cloud-based data is available, and this is the mean SMPG. And whenever there is a high glucose, especially after a meal, there is a high lipid, there is a lot of free fatty acids, and this can also drive the cerebral coronary artery disease. And this is the one of those reasons. You know that multiple reasons we have discussed in the beginning, and this is the clinical evidence with high mix. And when you are comparing the two, the low mix with a high mix, 25/75, and this is comparing with 50/50. 50/50 have more of rapid acting component. So 50% is rapid acting, the rest 50% is intermediate acting, and hence it will have a better action on the post-meal hyperglycemia. And this is another study at 26 weeks at the end of approximately 6 months. Those subjects in the high mix group when compared to low mix group had significantly more people achieving a hemoglobin A1C target of less than 7%, and also normalization of fasting and also the bedtime glucose level. So in the example that I have shown earlier, we have started at 12 units before the breakfast, and then you can uptitrate at 1 unit every day, of course, definitely based on your SMPG or CGM values, and then you can consider adding one more dose before the dinner over a period of time. And this is one classical example of a continuous glucose monitoring data with Libre sensor before and after. Look at the same person. Before, it is 42% time above the range, that is level 1 hyperglycemia. Level 1, that is above 250 milligrams, is 15% of the time, and only 43% is in normal range. Whereas this is 4 months after Humalog mix, it is 100% time in range. So the take-home message is timely initiation of insulin, and this has to be paired with structured glucose monitoring. So this is again a reminder, a request to all the friends, and this is an invitation for the 53rd annual conference of the RSSDI. And after a long gap of 14 years, it is getting back to the city of Kochi, wherever Johny comes from, and I am the organizing chairperson for this conference, and there is a registration desk at the reception here, and this is one of the biggest global conferences, and we are expecting more than 7,000 participants. Concluding remark, as doctors, as responsible doctors, be very, very brave to initiate insulin and also to intensify insulin. And analog insulins are far, far better in safety. The efficacy remains the same. In terms of safety in preventing hyperglycemia, analog insulins are far, far better compared to the human insulins. And please block your dates for JPEF 2026. It's going to be on 10th, 11th, and 12th of July next year. Thank you very much, dear friends.
Thank you, Jyoti, for that excellent, clear insight into the premix insulin. The session is open for a few questions, if anyone has. To set the ball rolling, Jyoti, I just want to ask you a question. Since our Indian patients are taking more carbohydrates, do you think that 50-50 will be a better insulin than 25-50, 75?
Yeah, I think 50-50 is unpopular in India, but as Johny said, I think 50-50 will be much better. But That need to be individualized based on SMBG data.
Western population, the carbohydrate is low. That's why they would have put on 25 thing. Whereas here India, we are more prone for carbohydrates. I think, is there any studies in Indian patients who were comparing these two?
I am not aware of any Indian study comparing, because more and more promotion is for a basal bonus therapy, which is more difficult to follow. I think this is a brilliant suggestion from our chair. So probably we should be using a 50-50 rather than a 25/75 or a 30/70.
We should do some research on that, I think, in our patients. Okay.
Do you have any suggestion, Dr. Rajiv Chola, on, because Dr. Johny is making a suggestion that in the Indian scenario, considering the high carb diet, we should be promoting more of a humulog mix 50-50 rather than a 25/75.
I agree, but it all depends on the eating pattern in different zones. Like in North India, not only we have a breakfast and dinner component, even lunch is very heavy in Delhi. So it is difficult to say that it will fit in every shoe, but definitely overall you may say that if a patient or a particular geographical group is taking more of brunch type in the morning and then they have only a dinner component, then probably 50-50 will be better. With 25-75 problem is that if you have a very heavy lunch, postprandial is going to be very high. So there are studies 1, 2, 3 that in between at lunch also you may give a premix analog. Novomix study was there 1, 2, 3 which said that if post lunch still remains high, you may do one maybe a prandial or maybe even Novomix at lunch. But this is worth looking into your own population, whether you can do better with 50-50 because of very high carb component. So if they are taking a heavy breakfast, not taking much of lunch, then 50-50 will be a very good option.
Most of the South Indian breakfasts are heavy with carbs. Idli, dosa, put, all these are high carbs.
You can initiate a study.
Yeah. Anyway, thank you.
We will join.
Thank you, Jyoti. Excellent insight. Thank you.